Hi, everyone. Thank you for joining our webinar today. I'm Derek Newell, as was mentioned. I've spent my entire career working for companies whose businesses depended on providing clinical and financial value for their customers. And I've also served as a consultant, helping purchasers evaluate vendors at different times in my career. And as a result, I've seen every trick in the book, and there are a lot of tricks. I know vendors make big promises about their impact on health and cost savings in their sales and marketing materials, but the ways in which they measure their impact can be misleading, opaque, and most of the time actually is not based on standardized statistical approaches. And at Virta, we founded the company with a clinical trial, and we've done a clinical trial on our outcomes and published those in peer-reviewed journals and had our research cited by the American Diabetes Association. So we believe deeply in the clinical outcomes and providing data that substantiates our claims. And this webinar is designed to help employers and health plans sift fact from fiction and to identify ways to evaluate if a vendor is delivering real results, both either through a clinical trial or actually, most of our data now is through operational implementations, and we have to evaluate in a real world setting, are we getting the outcomes? And I'm joined by a great group of people today. We have the Validation Institute and Willis Towers Watson, two folks who've been leading this effort in terms of validating outcomes and helping payers understand the impact of their vendor solutions. And we will open up with T. Montalvo from Willis Towers Watson. She's going to share some hands-on actionable analyses you can run to evaluate programs' impact based using data-driven methodologies. Then we have Artie Whitney and Linda Rydell from the Validation Institute. They're going to talk about how third-party validation is positioning to bring truth and clarity to the healthcare benefits world, specifically how Validation Institute measures outcomes for the healthcare and the wellness industry, and specifically chronic disease and diabetes solutions. At the very end, I'm going to share 6 common trips and traps in the healthcare vendor space that you can use to sniff out misdirection. The goal is so you can walk away from today with a toolkit on how to make informed decisions about vendor selection. So I'm going to introduce T, and then I'm going to hand it over to her. T. Montalvo oversees the North American Health Analytics practice at Willis Towers Watson with a team of actuaries, RNs, data scientists, and health economists. Her team leads data integration with other areas such as health management, pharmacy, absence and disability, and total rewards data. She leads some of WTW's most complex clients in developing multi-year measurement strategies and bringing forward data to support decisions. She has also pioneered analytic innovation for her clients in the area of establishing new ways to link data from traditional claims data sets to non-traditional engagement and employee experience data. So thank you, T, for joining us, and I'm going to hand it over to her. Thank you.
Great. Thank you, Derek, for that warm opening. Good morning, everyone. As Derek said, my name is T. Montalvo. I'm from Willis Towers Watson. Shannon, would you mind turning to the next slide? Okay. So I promise not to read the slide. What I just want to say here is just a few words about Willis Towers Watson, which is a company I'm very proud to be a part of. What I want to emphasize from this slide is just you can see the depth and breadth of our expertise. And I'm emphasizing this because as I talk about how we measure program value, you will start to see how we leverage the experience from these different areas to inform an integrated approach and our points of view on measurement. So this is exciting for me to be here to talk about measurement. It's obviously one of my favorite things to talk about, but even more than that, effective measurement of program value is very important. This is especially important given our economic landscape that has changed vastly in a matter of 3 months with the COVID-19 pandemic. With this heightened focus on spend, employers are asking now more than ever, do the programs I have in place have an impact, a value impact on the employees and families of my organization? And so with that, let's get started. Let's get started with how we answer that question. Shannon, would you mind going to the next slide? Okay. I don't always start with quotes, but this one in particular is important because I think Albert Einstein couldn't have said it any better. This is really the heart of the matter of the challenge we face when we're evaluating programs. Everything that can be counted does not necessarily count. everything that counts cannot necessarily be counted. This is essentially the struggle we have in measurement, right? Trying to strike the right balance between identifying the things that should be measured, those prognosticators or indicators of value, versus just measuring the things that can be measured because the data is available. And so I will start us with looking at first the common errors in measurement, and then walking through some best practices in measuring ROI or VOI and or both. So with each of the 7 that you see here, I will walk us through just a short illustration of why these errors are problematic. We'll start with selection bias. Selection bias occurs when we're comparing participants with what we call refuseniks or non-participants. The problem here that we are essentially facing is we're comparing like, and we're trying to compare like and like, but we're not actually achieving it because the participants are made up of a different makeup, whether it be health status, motivation to change, but then this will start to skew our results and it will diminish, if not eliminate, the credibility of results if selection bias is not controlled for. Second, regression to the mean. A really simple example of what this is if we think about a high-cost asthmatic 1 year, the following year, it is more than likely that asthmatic's cost will go right back to the mean, absent any program or intervention. Now, accounting for regression to the mean is necessary, so we're not inadvertently attributing impact or savings to events that would have happened absent the presence of a program anyhow. So it's very important to be able to control for regression to the mean. Overconfidence in the baseline. I think this sometimes gets overlooked, but it is very important. So studies have shown that when information is provided, whether it's directly correlated or not correlated to a program, confidence in the baseline probabilities for change increase. But this confidence or overconfidence is a false confidence, and it will have an impact on what the expected versus actual return on investment will be. The key here will be to weed out that information and data provided to ensure that it directly links to the program's leading and lagging indicators of value for impact. And then I'll move us along to this next one, small numbers. Small numbers it's as simple as this. The results that we see from a study, a small study, doesn't necessarily predict the same results we would see with a bigger study of individuals. So you've got to make sure that your denominator has strength in numbers so that when the study is replicated with a broader group, you would expect and you would see the same results come to fruition. Next, on number 5, this is an error that happens. And you watch any television ad on a weight loss management program, you'll know what I'm talking about here. So survival reporting bias. This is when, let's use the weight loss program as an example. Weight loss programs will tout the results about those who went through the program and the awesome results they got. What we're not hearing are those who dropped out of the weight loss program. We're not hearing the results of those that dropped off, and we're only seeing those positive results. So in this way, again, we're getting a view of data that's skewed and not necessarily reflective of the value of a program. And this ties in to another one we'll talk to about the end of publication bias. But before I go there, let's talk about short follow-up. Short follow-up is important because in considering how you measure, because a program takes time to mature. Often when I'm working with clients, there's a desire to measure program value within the first 6 months, 9 months, because an employer has invested the dollars into the program and they want to know, there's an anxiousness to know, has the program added value? Has it saved any money? Has it moved the needle? And what I tell my clients, I always ask them, let's take a thoughtful approach because programs take time to mature. behaviors take time to change. Going in and measuring within a short follow-up time will give results that are really not indicative of longer term lasting results. So making sure we take that thoughtful approach to when to measure will be very important. And then finally, publication bias. This is going back to that weight loss example. And it's as simple as we like to hear good news and vendors like to show good news. And we will not, if a vendor approaches employers, they are not likely going to show or publish results of studies that were similar that did not show an impact or showed minimal impact. So making sure we keep that in mind as we put a lens to the validity of a program evaluation is going to be very important. Now, let's move on to this next slide here, where I've walked through some common errors in measuring ROI and VOI. But now, how do we start to measure program value from a credible approach to ensure that, as I said before, we're counting the things that should be counted? So I personally really like to begin with the end in mind when I'm looking at measurement. So what I mean by that is explicitly tracing back what are the targeted program outcomes that have been stated, and then outlining those program outcomes to a business question. Framing things into a business question is very helpful because it will help to back into what I call answer metrics, right? So, and these answer metrics aren't all going to be used. Again, isolating what should be counted versus what can be counted. So, I think to illustrate this, it's probably best to give an example of how we do this. So let's take, for instance, a very common targeted outcome metric here of improving health and productivity. But I'm going to frame it in the sense of improving it through the use of an on-site clinic as an example. So the way this would move about from a process standpoint would be the business question to frame up would be, has the availability of an on-site clinic improved productivity? I like this example because I think a lot of people at first blush would say productivity is a soft metric. It's not a hard ROI metric. And I think I would beg to differ and say that this metric can be monetized to then become a hard ROI metric. And that's going to be something you'll hear me talk about throughout this discussion. It's the monetization of metrics as well as adding some value rating to metrics that are not immediately quantifiable. And so in this example, the answer metric I would use, or one of the answer metrics I would use to answer the business question on productivity would be to look at time away from work. So calculating the difference in time away from work for an employee that accesses the on-site clinic versus having to travel to a doctor visit. And then layering on top that time differential will be the average salary of the population. And in that way, you can back into a monetized value for the metric of time away from work. And then you bring those metrics together, both the quantitative value that you get from the on-site clinic, as well as these qualitative values that have been monetized, and you'll be able to formulate an understanding of value impact in this example of an on-site clinic. The goal here really in going through this exercise of first figuring out what to count is to make sure your end result, the results that are provided to you, are really reflecting what the targeted program outcome was or outcomes were to begin with. And framing it in business questions is just something I really like to do because it's an easy way to make sure you understand what you're solving for and also to identify those answer metrics to get to whether or not the program is adding value. And then I think invariably, as you go through this process with any program, any business question, any answer metrics, you will find two categories. You'll find a category of metrics that are quantifiable, very easy to kind of bucket towards ROI. And then you're going to find a set of metrics that are qualitative. And you're going to need to do some massaging of that data to monetize or apply some value impact rating to it. And I'll move us to the next slide to talk about how we do that more in practice. So we've talked now about the 7 common errors to avoid in measurement. We've talked about starting with identifying the counts that matter. And now structuring the approach of measurement is key. In structuring that approach, in order to ensure credibility, one, you will want to, and I will circle us back to, you will want to try to control and or avoid those seven common errors in measurement that I spoke about earlier. But then you'll also want to make sure that your measurement approach is transparent. Transparency is going to be key, and I'll talk about that as we go through this particular page. And then you want to make sure the methodology, the study can be replicated. If you have those 3 in place, I'm almost positive your results will always stand up to scrutiny. So let me start with something that we do here at Willis Towers Watson as a best practice when we're asked to evaluate a program. In terms of evaluation, it's not just about the hard dollar return, the ROI. We cannot ignore VOI, the value on investment. In looking at both ROI and VOI, we can ascertain an answer on program value that moves us forward with a focus on measurement by objectives. And what I mean by that is that we're measuring by the objectives of the program at hand, and we're also measuring by the broader business objectives of the organization, of the employer. That is going to be very important. Looping back to the employer's organizational values is critical as we consider a program that truly provides value, will do so in generating both economic value for the organization as well as intrinsic value. So how do we do this? Let's start with the easy part, right? So the economic value, those are the quantitative measures that we often use for ROI, changes in trend, changes in spend. I will say I'm probably of the school of thought where absent the ability to perform a randomized study in a benefits environment, I do really prefer to perform a match case cohort analysis. And layering on that, the calculations of difference in difference and statistical testing. All of these 3 components are important because going back to selection bias and regression to the mean, the match case cohort analysis allows us to, if set up correctly, allows us to compare like to like. And the statistical significance allows us to answer the question of whether the results were random or were they a direct result or correlated to the program itself. And I talked about transparency earlier. This is where transparency becomes very important because as we're setting up our analysis and methodology, being transparent about how we did this, how we matched a participant with a non-participant, what criteria did we use? Do we truly have what I like to call a digital twin of each in the cohorts to the best that we can with the data given? That's going to be key as we make sure that we're controlling for selection bias and regression. And then, so as we think about those economic value metrics, you can do so in setting up this match case cohort analysis and pulling in the productivity metrics as well. But now let's move over to something that's a little softer and requires some massaging of the data, the intrinsic value. Over to the right, you'll see here I've listed for intrinsic value some examples where intrinsic value would be embedded in things such as improvement in health status or behavior change. So what I mean here is when we think about a program adding intrinsic value to an organization, we'll want to think about the leading and lagging indicators of intrinsic value. Let's take engagement rates and NPS scores as an example of leading indicators of intrinsic value that that then get us to those lagging indicators of the intrinsic value of an improved health for the population. And the lagging indicators, if we use an example of a diabetes management program, could be a change in HbA1c over time or medication compliance. Those lagging indicators immediately would not appear to be something that you can back into for monetization, but you absolutely can. And that's where I would say making sure that you've identified the metrics that matter, the metrics that should be counted, relevant to the program, relevant to organizational value is going to be key. Because in certain metrics, as you monetize, you will also maybe shift over to like a value impact rating. And what that will mean is once you have all your metrics laid out, both from all the economic value metrics to the intrinsic value metrics that the program provides the organization as a whole. The approach I like to take is then creating weightings for these metrics or these domains. And these weightings are then looped back to the organizational value and objectives. Right? So you're weighting it based on what the organization expects and needs. And then you'll get to what we call a value impact rating or score for the program you're analyzing. And in this way, you're looping both ROI and VOI into the analysis. So I know this was a lot that I just said here, but there's so much to this. I know we have limited time, but I do want to summarize with what we would recommend at Willis Towers Watson and what my team does routinely for many of our employers in evaluating program value are: 1, avoiding the 7 common errors in measurement that will diminish or eliminate the credibility of your results. That is really critical from the get-go. Just make sure you're controlling for it and or avoiding it. 2nd, taking a thoughtful and sometimes I will say painstaking approach to identifying what should count. Consider what you can measure, consider what you can count, and figure out where you're going to get those measures and how, if you need to, you will monetize and add any kind of value rating to it. And finally, in a measurement approach, it is critical that the approach not only address those 7 errors, right? Putting those into an area where you've accounted for them, but also that the approach is transparent. The details are there. There's nothing hidden. There's no hidden secrets, right? And then that it can be replicated. These things will be key when you're analyzing program value. Thank you.
Thank you, T. Appreciate your time and your insight. I'm going to quickly introduce Artie Whitney and Linda Rydell from the Validation Institute and turn it over to them quickly. Artie Whitney's career has been focused on developing communities that bring buyer and seller together through the gravity of education. This includes events, research, databases, peer learning, and sponsored memberships and businesses. He has a track record of building and growing community assets to maximize value for members and investors, and has a long career prior to the Validation Institute, and has had roles at the Taurus Group, Diversified Communications, Bloomberg, as well as a long list of other endeavors that he's been a part of. Ms. Rydell has worked in health insurance and healthcare since 1985. She works with clients to measure the impact of management and wellness interventions and to convey the message to stakeholders, including patients. Writing about and presenting population health science concepts and studies has been a focal point of her work. She has developed numerous online courses for health insurance brokers and human resource professionals about using population health science to choose and evaluate wellness vendors. At Validation Institute, she oversees the validation reviews of health and wellness vendors. She holds degrees from the University of Cincinnati, Southern Maine, and the Johns Hopkins Bloomberg School of Public Health. And so thank you very much. I'm going to turn it over to you folks for the next section of the webinar. Thank you.
Great. Thank you very much, Derek. Go to the next slide. So one way to describe what the Validation Institute does is it sorts the facts through the fiction. For the employers that are on the call today, and the advisors that advise the employers, and the solution providers that eventually want to reach the employers, lots of marketing claims are being put out there. Some of them are accurate and some of them are not. Here's an example of what you might see out there, and what the point of today, and there's a very common theme throughout this entire webinar, and you will get more into detail with Linda when she talks about our approach, our data science team approach to validation. But that is what's out there as an environment. Next slide, please. So, when you are picking one of these programs as an employer, you're hoping that the promises are come true. You're putting your career on the line, really, for it. You're putting your company's money on the line and your employees' money on the line. So it's critical to make sure that the claim is accurate and trustworthy. You're trying to get the detail behind the numbers. You don't want vague claims of what a program can do or not do. You want the details. And then, you more and more what you're hearing out there, and you will start to hear this more as companies like Walmart and Comcast and Michelin, lots of other organizations around the country, they're looking for a third-party, non-biased group to help them validate that performance claim, because they are putting a lot at stake on that, and the advisors bringing those to those employers. Next slide. So that's exactly what the Validation Institute does. And just a little quick history on us. We actually spun out of Intel and General Electric. They were coming out with a healthcare point solution, just like the many that come out on a daily basis, and a ripe area for funding. There's lots of problems in healthcare to be solved, and there's lots of solutions coming out. They all make performance claims, marketing claims, some of them accurate, some of them not. So Intel and GE had come out with one, and they thought that this was kind of crazy because their competitors were making claims they knew were mathematically impossible. So they got third-party independent funding to create the Validation Institute. So what does that mean? It is sort of the Good Housekeeping seal of approval, or the underwriter's laboratory of a marketing claim. And in fact, GE and Intel's program couldn't make it through validation actually in the beginning. But that later got commercialized and invested in by people that are very passionate about helping to get rid of what Warren Buffett calls the tapeworm in American competitiveness, the crazy healthcare system where employers are spending $1.7 trillion of healthcare spend, and it seems to be no end in sight for the rampant growth. What we found when we got involved with the Validation Institute, and my background has been building these institutes. I recently built the Institute of Finance and Management, for example. When we find an area that's cloudy, where it's not transparent, we find it can be dramatically improved with education. So on the validation side, a vendor can be validated, a solution provider can be validated, and that's helpful to the employer and to the advisor bringing it to the employer. On the employer side, what we found was the HR departments and the groups bringing in healthcare for their employees were getting their education from the exact same establishments that make more money when their rates go up and their services go down. And they knew who they are. So there's no way it's going to improve that way. So what we did was we launched the first national certification program in America, recognized by SHRM, for the HR professional to learn about the techniques of buying health value. And so help validate the vendors, help educate the employers, and then bring them together. Next slide, please. A perfect example of that are, we got vendor A and vendor B. So here's a way, and Linda's going to talk in more detail about these techniques to watch out for, and this is taught in our coursework as well. But here's an example of how they just really don't compare when you boil down their performance claims. So there are things to watch out for, and we do that for the employers and the advisors, bringing the vendors to the employers, and also we help educate the employers how to do it and look for these things themselves as well. Next slide, please. And here's the question: is where the rub is? Is there real money at stake? Some of these areas in particular can result in tremendous savings by learning about how to apply health value techniques, bringing in the high performance vendors with validated claims, and improving the healthcare for your employees and really improving the bottom line for your company. So the difference between high performance vendors and solution providers and standard ones where the performance isn't being checked is dramatic. Next slide, please. So I'm going to turn this over to our Chief Data Scientist, Linda, to talk about the validation process itself.
Am I on?
You're on.
I'm on. That fabulous. Okay. Next slide, please. And this is companies that already mentioned. Here we go. What validation review entails. So there's three things that are part of a validation review: the intervention, the data source, and the mathematical model. So the intervention, what we look for is to see published peer-reviewed studies on a similar intervention having the same impact that the vendor is promising. So, for example, has health literacy been shown to reduce emergency room visits? And indeed it has. Or if you get people with diabetes to fill their prescriptions on time, can you eliminate their hospital stays? Well, you can reduce their hospital stays, but not eliminate them. So we do that literature check to confirm that what they're doing has been shown to have the impact. Now, a lot of programs will say at this point that they're utterly unique and that they can't be compared to other programs. Well, their program might be unique, but their goals are not. So reducing costs, improving health status, improving productivity, all of those things are not unique. And as T mentioned, measurement is not unique. So they have to be utterly transparent about the measurement. And if they're not, it's generally a sign that they don't know how to measure. Data source. Now, the data source can be any number of things: medical claims, surveys, enrollment, clinical assessments, app traffic, any of those kinds of things. The focus here is on credible and reliable. A survey, for example, if it's a validated survey, that means it's been studied and shown to elicit consistent and reliable responses. A non-validated survey is not gone through that process, and the quality of the data that it provides will be lower. So there's all kinds of issues that are well beyond our scope today, disadvantages and advantages of different data sources. So let me suffice for here to say data source needs to be solid. The mathematical model. T talked a lot about this earlier, different types of approaches. Generally, vendors in the marketplace are looking at pre and post. They're looking at what happened before and what happened after. It's probably the most popular approach, and it's fine as long as it's done correctly. Excuse me, all groups have fluctuation, and so the changes for pre and post need to be expressed as a rate. Different kinds of things have different conventions about how their rate is shown. Emergency room visits are usually shown as per 1,000 member months, for example. But there's other reasonable approaches besides pre and post. The case cohort study that T mentioned, comparing matched groups, comparing to a published benchmark. So that's our third focus point. So in the short time that we have, I want to just show a few examples of problems that you can spot for yourself in looking at vendors' claims. Next slide, please. Vague terms. Healthier babies, happier patients, reduce costs, better patient outcomes. This might be all over the headlines of the vendors' promo materials. But what is a healthier baby, and how is this measured? So the hallmark of a good, clear measure is specific terms. So instead of healthier babies, it could be something about the ratio of babies born at low birth weight as a ratio to all live births. If you have a program that can tell you that that's what their goal is and that's what they're going to have an impact on, you've got a good start to having some accountability and a measure that you can follow. Next slide, please. T talked about comparing participants and non-participants. This is very popular amongst vendors. I'm not sure whether the majority of them know that participants always will perform better than non-participants, or whether they think that it's credit to the program that the participants were so wildly successful. But as T mentioned, participants are not comparable to non-participants for a variety of reasons. T also mentioned about regression to the mean. So lots of programs specifically target high cost or patients who have had 2 emergency room visits in a 60-day period, for example. All of those people, as she mentioned, are on their way back to average. So programs that target those members and track only them pat themselves on the back for what would have happened no matter what. So a better measure for addressing this issue is the entire group's rate of cost. So for example, you might have a program that targets diabetes, hospital admissions. So a better measure of the program's impact would be the entire group's rate of diabetes-related hospital admissions. It would show you, A, did the program recruit the right people? And B, what was the impact on the entire population? So just different approaches to escape the participant and non-participant problem. Next slide. This is another very common strategy of just claiming savings and not giving any detail at all. Our program saves millions of dollars. Our program delivers $4.2 for every dollar invested. The trick here is to get them to respond to say what costs or events went down, how are savings calculated. Very important to include the cost of the program so that it's nice if a program saves $1 million, but if it costs $1 million, what's the benefit? So encourage people to demand the detail. And for example, instead of the 4.2 to 1 ROI, you'd rather have a statement that says we saved X dollars per member per year. Remember, it's a rate. Net of program costs, we did that by reducing spending on inpatient hospital care. And next slide, my last one. So what you can do as employers and purchasers is to sharpen your skills for sniffing out these kinds of errors and hype. Demand the detail behind their claims. And naturally, you can ask for independent validation of their results. So I hope that was helpful, and I think I'm turning it over to Derek.
Hey, back to me. So I'm just going to quickly go through some of the common tricks that I've seen. T mentioned some of these, so these have been highlighted throughout, but they're kind of some of the quick heuristics or the quick thing, like a checklist that you can go to see if the data that you're seeing from someone is likely valid. So I'll go through that. I'm going to spend you can go to the next slide. I've got control actually. So a little bit about me. background in public health and public policy, health policy. Did an MBA and PhD at Berkeley. And I've been in, as I mentioned, in digital health for a very long time. I was the CEO of a company called the Health Hero, which was the first internet connected medical device that was ever approved by the FDA. So I'm been at this a really long time. And I've worked in disease management at medical groups, trying to prove like, what's the impact of what we're doing? Like, what's the real impact, both on clinical quality and on cost savings? And when I saw the explosion in the digital health ecosystem in the mid 2000s, sort of around 2010, 8 to 10, I founded a company called Jif because I believe that getting that digital health ecosystem connected to the benefits systems would be really, really difficult, that there would be an overwhelming number of solutions that would be beneficial to people, but buyers wouldn't be able to connect them and absorb all of that competing sort of, wouldn't be able to manage that complexity. And you see that today with vendor fatigue. Sold that to Castlight, and now I'm at Virta, as I said, because I believe that the delivery of care and the disruption of the delivery of care is fundamentally what needs to happen. And Virta is a great place for me to work on that, as we're a medical group that delivers diabetes reversal. So I'm going to talk a little bit, been thinking and selling a long time on clinical and financial outcomes in my different jobs. And I want to talk a little bit about the things that I see, the traps. The worst and most unforgivable one is fabricating data. We all like to think this won't happen, but it happens with more frequency than anybody would like, and sometimes at massive scale. And the two biggest examples are Theranos and Duke Oncology. The best way you can do is make sure that you dig down into the data and hire a third party to validate the data. What happened at Theranos is everybody referenced on somebody else. Well, this person's smart and they have already looked at it, so everything must be okay. And everybody did that, and basically all around the circle, everybody looked at each other and like, they told me it's a good idea. And everybody else thought that everybody else had basically done the due diligence, and none of them had done the due diligence. It's kind of like the bystander problem, which is the more people are around that see something bad happening, the less likely it is that somebody's actually going to call authorities because they think that someone else has already done it. And so when somebody references, well, this person who's really smart and really good says I'm okay, that's an important reference point, but it's also important to make sure that you do your own due diligence. Over extrapolation is another one. This was mentioned both by T and by the folks at the Validation Institute, where you take a small study and you extrapolate it, and it's not really valid. And we've seen this for hydroxychloroquine, which is bounced back and forth. Oh, it works. Oh, it's dangerous. Now maybe it works. Now we don't know. And so this rush to understand without evaluation and or to over extrapolate things is always a challenge. Couple of other things is maybe there's no statistically significant change in the study, but the line goes down, and so they claim it's a statistically significant study, or they apply it to, they take a study in one area, maybe hypertension, and they apply it, or weight loss, and they'll apply it to diabetes. So that's a big one. Another really common one, and sometimes you have to do this, is co-opting. So you use the data from one study to validate your intervention, even though you weren't part of that study. So pure co-opting, sort of, I didn't do the study, not part of the clinical trial, but this other person says they can do that, so I'm going to do something similar, and I'm going to purport that I get the same results. That's another thing. That's one thing which I think happens commonly. So it's always important to make sure that the study that's being proposed is actually the vendor that was in the study. And then often we all use this for difficult to measure outcomes. So there are some things that can only be measured over decades. And there's been very large, very rigorous studies, and everybody points to those studies. Even the folks at your benefits consultants will say, well, if you get this much weight loss, it's likely to turn into this much economics. And these are the studies that the government has funded. And so those are really big studies. That's a common way to co-opt a study. ROI calculators are super, super dangerous. Whenever you see one, you should be cautious, because they're using a very simple methodology to get your attention as a marketing tool. And so we do opportunity analyses, and we analyze your claims data to tell you how much we think we can impact. So it's important to be able to do this, but they often have fallacies like regression to the mean, like I'll pick all the sickest people, or I won't compare the people to a good control group in the previous population. Whenever I see an ROI calculator, a red flag goes up for me automatically, because I know there's a lot to dig into there. Cherry picking data is another one. And we always have to try to make the data, the group that we're comparing to, as similar to the group that we intervened with. So we exclude patients. You can exclude patients with poor outcomes. You can exclude patients with, there's a lot of different actuarial and other tricks to exclude patients that should be included. And you might do only completers, or you might hide retention numbers. And sometimes you can't, sometimes there are no complete, like sometimes it's really difficult to solve these problems. But even for an intervention where you have completers, but you don't have data on people who didn't complete, so you theoretically can only analyze the completers, there are statistical methodologies that you can use to predict what would have happened with the people who didn't complete, because you have data on people who dropped out at different points of time. And if you have a sophisticated team, you can calculate and put in relatively good numbers for those people who didn't complete. So there's always a valid way around many of these challenges. The problem is many vendors don't like the outcome when they put that data in, so they don't include it. The other one is just unvalidated data. This is a big push that we're making, that we've been making in the industry, is obviously we have peer-reviewed published outcomes, but really it's the third parties that need to show up and validate the data. And as vendors, we can support those third parties by subjecting our results to their scrutiny. And as purchasers, you can support those third parties by using them and looking at their data sets and using them in your evaluation criteria. Because that's really the only way to know. It's like, get an objective third party to look at the data and to validate the outcomes, and to help you understand, are the methodologies that are being used valid? So those are the big things, and we're obviously a big fan and supporter of WTW and the Validation Institute and Milliman and others that are doing this great work out there to help us level the playing field in terms of making sure that purchasers are getting value when they partner with vendors that claim to produce an outcome that is important to them. So we'll turn it over. We're going to take some questions now. Take a few questions. Shannon, are you going to moderate the questions? Do you know what the questions are? Oh, I'm going to skip a little bit. I've already talked a little bit about Virta, but we're a fully virtual provider-led clinic for type 2 diabetes that reverses diabetes. And what reversal means is we help people get their blood sugar under control, while at the same time getting them off of all their medications. And that is something, that's why I'm here. I've never in my entire career had heard of any company that could do that. So we have a provider-led medical group that supports patients in a medical nutrition therapy that takes them off of all of these incredibly difficult and highly drugs with lots of side effects, and gets their blood sugar under control. And the patient outcomes are just amazing. It's incredible. We have dozens of testimonials on our website, and probably hundreds of them at this point. Okay. I'm going to skip over. I'm going to leave time for questions.
All right, no worries. And while I move over to our ending slide here, we do have a couple of questions incoming from the audience. I guess to kick off, a question for you, T. And asking on behalf of the audience members here who are interested in diabetes solutions, what are some good examples of diabetes solutions or vendors who have demonstrated ROI? And are there any verbal or anecdotal feedback you've heard as well from the data that you've seen and across industry as well?
Sure. So like I said, our team has performed a number of ROI analyses for our clients. I can name two, one of them, which is Virta. We have seen some promising results for Virta in a mature rollout of Virta for one of our clients, both from value, impact, as well as an ROI. But again, a mature program. And then also in a pre-diabetes program for Amada, we've performed that analysis. And I would say in that analysis, we're seeing what I call early prognosticators of potential ROI in the coming years. So it was an ROI study that was performed early on, and I'm looking to see the program mature a little bit more.
That's great. That's really helpful. Another question for RD and Linda. For employers and health plans who are looking to make a decision on vendors, do you have any suggestions on where they can start? I'm just thinking, does Validation Institute, for example, publish their database of validated solutions? And for example, if an employer is wanting to find a ranking of like the top 10 diabetes solutions and vendors, for example, is there, where can they kind of start to get a sense of what that picture looks like?
Yeah, so I can take that. We publish all active validated programs on our website, validationinstitute.com / you'll see right there, view validated companies if you go there. So you can find that, you can sort that any way you want. Now realize we validate programs within companies, not the entire company, because there's going to be some good examples of companies that are doing things that can be validated, and some that, programs that can't. So that's one. And then two, we have as well off of our website something called the Validation Institute Exchange, and kind of think of this as the all-in database. Like, so we have 1,700 companies listed there, and descriptions of the companies. There's 26 fields of data of each company, and it'll tell you about them. And they're ranked by, certainly the rising to the top, which is what we want, are the companies that have validated programs. Companies that are involved with the Validation Institute Awards program, which happens every year at the World Healthcare Congress, those are going to rise to the top as well. And then, obvious category killers that you would be surprised if you didn't see them there, and then everyone else, because it's such a long list. I mean, telehealth is an extremely popular area right now. It's growing by leaps and bounds. There's over 100 vendors just in that one category. So those are some resources that could be helpful.
Absolutely. And a question for you, Derek. One of our audience members would like to know more what the definition of diabetes reversal is and how that might be different from diabetes management and other terms floating out there.
Absolutely. Let's go back to the earlier slide a little bit, and I can give a little bit more overview of Virta and what that means. Do I have the control? Can you give me control? No, I'll just do this.
Sure.
The main difference between the diabetes reversal and diabetes management is that this slide right here. So these are the clinical outcomes, our 2-year clinical outcomes. We're publishing our 3.5-year clinical outcomes. But as you can see, what happens in the first year is a dramatic reduction in A1C. Also, there's this beautiful side effect of a dramatic reduction in weight at 12%, 14% body weight reduction, 12% maintained over 2 years. And what happens in most diabetes management programs is they monitor folks, they give them light coaching, and they get a small A1C improvement. And that's because they increase adherence to their drug protocol. So they're on insulin or they're on other drugs that help them manage their glycemic control. And so what management does is encourage people to follow diabetes care protocols, including taking their drugs. And so in most usual care settings, you'll see an increase in the cost of medications over time. And you'll actually, in this case, you'll see an increase in, this is compared to usual care, not compared to a diabetes management product. You'll see an increase in not only A1C, but an increase in RX costs. So the core of our treatment and reversal is to get people off of all of those diabetes medications. As you can see on a population basis, after 2 years, people were using 60% fewer medications while achieving dramatically lower A1C results. And that's the main difference between reversal and management. Is it's a physician-led intensive treatment program where we will supervise people's lifestyle medical nutrition therapy that's endorsed by the American Diabetes Association, cited in their standards of care. And we are able to get people off of, in fact, 94% of people either eliminated or reduced their insulin usage in our treatment. And so that's the main difference.
Great, that's really helpful. Thanks, Derek. And with that, I think that pretty much wraps up the questions that we've seen in the chat box. Thanks again, everyone, for tuning in. We really appreciate your time, and it was a great opportunity for us to be able to speak with such esteemed speakers in the industry as well, and for this collaboration to happen. So thank you, RD, Linda, and T, for joining us today. And for all the other questions that you do have, please make sure to send them over. We'll try to get back to you with a response as soon as possible. So thanks again, everyone, for joining, and have a great rest of your day.